Hello, everyone, and welcome. I am Autumn Lintz, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here. Before I introduce our wonderful panelists, I would like to go over some housekeeping. We are here for Q&A. That's why you joined us. So there is a tool in Zoom where you can enter your questions. So if you could please go into the Q&A tool and enter your questions throughout the webinar. We will be recording this, and the video will be available on the Foundation's YouTube channel in a few days. We would also like to thank our individual donors and our funding partners for making programs like this possible. We cannot do it without you. This is how we exist, and this is how we are able to produce patient education forums, webinars, publications, and other education materials, so thank you for your donations. Upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. Now, I would like to share some information on our speakers for today. Today we have Dr. Erick Lansigan and Dr. Debjani Sahni. Dr. Lansigan serves as Program Director of the Hematology and Oncology Fellowship at Dartmouth Cancer Center. He has over 21 years of experience in the medical field. He is the co-director of the Cutaneous Lymphoma Multidisciplinary Program at Dartmouth and leads the clinical trials program in hematology, including clinical trials cutaneous lymphoma. He is also a member of the Medical Advisory Council for our foundation. Dr. Sahni serves as director of the Multidisciplinary Cutaneous Oncology Program at the Boston University. She specializes in the care of cutaneous oncology patients, including cutaneous lymphomas, and the medical management of melanoma and high-risk non-melanoma skin cancers. She also directs the Cutaneous Oncology Fellowship in the International Program in Dermatology. Her clinical research interests focus on the epidemiology and treatment of skin cancer. She is also a member of the Medical Advisory Council for the Cutaneous Lymphoma Foundation. Let's go ahead and get started and welcome Dr. Lansigan and Dr. Sahni. Thank you for joining us today.
Thank you for having us.
Thank you for having us.
Wonderful. So we're going to go ahead and get started, but before we go to our first question, as a reminder, Dr. Lansigan and Dr. Sahni are here offering their opinions and answers to your questions based on their experience in the field and experiences with their own patients. These are not second opinions, and any questions that you have, you should always take to your own medical providers. So let's go ahead and get our first question. This one was a little longer, so we split it into two parts. My mom is Sezary stage 4. We are happy her blood is managed well through MOGA infusions, but now her skin has progressed into large cell transformation. She also deals with swollen lymph nodes. She has been receiving radiation treatments and also just started interferon injections. And the questions that this person has is, can we expect more treatment options in the near future that targets the skin and lymph nodes? And what can we expect as far as the development of future treatments and their effectiveness?
I can take that question. Happy to do so. And thank you for having us, Autumn, and welcome to the audience watching. I think this is a great forum, and we hope to give you a lot of good information here. So I'm Erick Lansigan. I'm a hematologist, medical oncologist, and so I do treat cutaneous T-cell lymphomas. And so the question is regarding large cell transformation after mogamulizumab. And I'm sorry that's happening to your mom, but there are a lot of treatment options at this point. I think total skin radiation is an option depending how extensive the tumors might be, or if it was a tumor or a thickened plaque or large cell transformation. That needs to be addressed by your medical oncologist. As for treatment options, there are many. What I'd like to use is a drug called Taxol, so that will be an option. It's a form of liposomal doxorubicin, but there are some parameters of the heart that have to be met in order to get that medication. I would also want to ask your medical oncologist, did this tumor or skin lesion express CD30 on its cell surface? Because that would also give an option to be treated with a drug called brentuximab vedotin. So those, would be two drugs that I use a lot in my practice for large cell transformation. If Dr. Sahni has additional comments, maybe you want to take that. But if not, I hope that did answer the question.
Those are the
All right.
typical go-to as well, so I don't really have much more.
Okay, thank you very much for that very thorough answer. Our next question, is there any merit to epidermis radiation?
Yeah, so we consider the total skin electron beam radiation as a very good treatment for large cell transformation and tumor stage cutaneous T-cell lymphoma. This needs to be given in specialty centers that have electron beam. So you have to ask your facility where they deliver this type of treatment and if it's available in your facility. It is a good treatment. It is a very involved treatment. It does require a lot of expertise because there are different schedules that can be tried. We tend to use an abbreviated schedule in the beginning to see what the response would be, because there are side effects to the skin when you do total skin radiation, and it's a whole procedure which requires expertise and positioning patients in certain ways. So all the electron beams hit the entire skin, and that's why it's called total skin electron beam radiation. And it's very effective at controlling the disease, but often after that radiation is given, some sort of maintenance therapy needs to be given as well. And that maintenance therapy can be ECP, which is photopheresis, which you may have heard of. Extracorporeal photopheresis is the full name. Interferon could be used as maintenance if tolerated now. So that would be a good reason to try the interferon for tolerability, and it could be maintained after radiation.
I just, Dr. Lansigan gave a very detailed explanation on total skin electron beam. Another way to use radiation is just for localized disease. So if you don't have tumors all over, perhaps they're just localized to a certain body part or a limb, that can be targeted very easily by the radiation. And typically, the CTCL, it's very radiosensitive, so you can get very good responses. And because they use superficial electron beam, you can actually radiate that area again if another lesion comes up close by. So that's a good way of doing local disease.
Thank you both for that. All right, our next questions. As more patients are being offered MOGA and we are learning more about its effectiveness, are folks able to take breaks and resume treatment when necessary with success? We always seem to get a lot of questions on MOGA, and this is a common one.
Very good question. Yeah, it's a great drug, and we're so thankful to have it approved and now being widely used. And it's well tolerated. Hopefully, there are not a lot of reactions and side effects. So if someone is having a great response and is looking for a different schedule, I have been able to lengthen the amount of time between doses from every 2 weeks, and then we might move to every 3 weeks, and then possibly 4 weeks. This has to be done under close supervision of your treating oncologist. What I find is that out in the community, if a patient is getting this drug through their local oncologist, they're not monitoring the skin as well as in our multidisciplinary clinic. So I would make sure that there is good skin follow-up with the dermatologist managing you. just to monitor if there is any breakthrough of any new lesions on this new schedule. I've been successful doing that with other drugs, including a drug called romidepsin, which was also on a very similar schedule, and that is not an antibody treatment, but we were able to increase the intervals for patients who are responding. Since mogamulizumab is an antibody treatment, it's a monoclonal antibody, it does stay in the system for longer, up to 90 days, in fact. So I do think it lends itself well to other schedules, but again, under close supervision.
Yeah, and we've had a very similar experience to Dr. Lansigan. So, as you mentioned, with other drugs, we've done it with romidepsin as well, and pralotrexate, and even with Taxol, where people are doing well, we like to give them a bit of a break and spread out the interval if possible. And as he mentioned, close follow-up is key. So if anything reverses or any lesions start progressing or coming back, we see the patient straight away.
All right, wonderful information. Thank you. The particular treatments like steroid creams, light therapy, and radiation are thus far controlling the disease. Is it best not to deviate from that with experimental treatments like clinical trials and drugs? It's a little bit of a toughie on that one.
I don't know what Dr. Lansigan feels, but I feel that if something is working, I would stick to that. And at some point, some of these with the lymphoma, some of these treatments stop working eventually, and so you don't want to use up all your resources up front. And I think it's better to keep on to one method if it's working very well.
I completely agree with that. As I lead the clinical trials program in cutaneous lymphoma and blood cancers, we very carefully select patients and would only offer it if truly needed. And yeah, so I don't tend to deviate from things that are working really well and only offer things when we think that it's needed, if the disease changes or progresses. That would be a time to look for experimental options if they're available.
All right, thank you. So we have a question on stem cell, but before I ask the question, I do want to mention to everyone that we are actually in the process of working on a stem cell video series and hope to have it out within the next 2 or 3 months with some information. So just keep an eye out. Once we have those videos, we will send out emails with them. What are the basic requirements for stem cell transplant? What makes a good candidate?
I can take that as usually patients would have failed a number of their treatments, or treatments stop working, and then need to be considered for stem cell transplant. So the people that we would consider for it would be, so there are different components. It would be the type of cutaneous lymphoma that they have, cutaneous T-cell lymphoma, I assume we were talking about. And some of them tend to be more aggressive. You may hear terms like gamma delta, but it is really the clinical behavior of the cancer that we care about the most, and its status in regard to prior treatments that have been tried. So if you meet that requirement of an aggressive lymphoma, or what we call a refractory lymphoma that's not responding as well to prior treatments, then we would consider you for the stem cell transplant. And then I tend to refer our patients to my colleagues at Dartmouth who do stem cell transplant, and they take into a number of considerations, which include comorbid conditions, like what other medical problems. We take into account age, and then we also look at the donor availability. Who is the potential donor? Is it a sibling, or is there a match within the the National Registry of Donors? So we look to see if, what capacity there is a match, or what is the how many matches are available, and what kind of donors are available. And then there are formulas that our group uses that take into account different laboratory values, different patient medical conditions, and then we can come up with a risk score about how patients would do after the transplant. So it's a very involved assessment, and this is done at specialty centers that have bone marrow transplant or stem cell transplant available. And then you would have the ability to ask many questions like this directly to the physician. So in general, that's how we assess our patients.
All right, it was great information. I know that not a lot of our patients end up doing stem cells, but everyone has questions on it because they know that it is a possibility in the future. All right, our next question, a skin biopsy came back positive for CTCL mycosis fungoides, yet a lymphoma specialist said it was unlikely that I had CTCL. I'm confused. I had 2 episodes of severe lesions, which eventually went away. Is it possible that the disease could reappear? Can you explain how a positive skin biopsy could also be false?
So I can take that one. So cutaneous T-cell lymphoma is difficult to diagnose. It's not one thing that they're looking for under the microscope, and it's made up of how the rash looks to the clinician, because CTCL has like a classic look about it, which we all recognize, but it can also mimic other conditions. So, for example, psoriasis, eczema. So we're looking at how the clinical appearance is, as well as what's under the microscope. And under the microscope, there are several things that they look for as well, and there can be overlap with other conditions. So it's unusual, although it does happen sometimes, that it will come back as mycosis fungoides and nothing else. Like it's diagnostic of mycosis fungoides. And typically, if the clinician agrees that that's how the rash looks clinically, then the diagnosis is made. But often than not, the diagnosis has certain features that are found in CTCL, but also has features that could do for another skin condition. And sort of, especially if it doesn't look like classic CTCL to the patient, if it looks like a different condition such as psoriasis or eczema, and you've got a clinical appearance that's not 100%, and you've got a pathological appearance that's not 100% diagnostic, often a clinician will not make a diagnosis of mycosis fungoides and kind of wait it out and see what happens to the rash.
I'll comment further because we review all our cases at a multidisciplinary tumor board, and we review all our path cases there. What we see sometimes is that the initial biopsy is sent to a central pathology, not affiliated with specialty specialists like myself or Dr. Sahni, or a specific dermatopathologist who specifically is trained to read these biopsies. So sometimes the diagnosis will come back, or they don't have all the clinical information. But when it's put together by the specialist, lymphoma specialist or a dermatology specialist, then we can piece together whether this is truly represents a cutaneous lymphoma versus what we call pseudo-lymphomas, other mimickers. There's something called lymphomatoid papulosis. So there's so many other things that it could be, and that's why I think it's really good if there's any question to refer to your nearest program in cutaneous T-cell lymphoma or what have you, academic centers usually. And the cutaneous lymphoma website has the list of centers that specialize in this disease, and you can seek out another opinion if you need.
Thank you, and I'll add to that. So on our website, under patient resources is treatment centers, and you can either search by the name of the treatment center or use the map to find something that is near you. All right, our next question. Are there any new treatments available or in the pipeline? There's always something in a clinical trial somewhere.
Yes, we are participating in clinical trials at Dartmouth. We're enrolling patients into a trial with a drug called lacutamab. It's an antibody, monoclonal antibody that targets a protein in the something called the KIR family. And this is recruiting patients worldwide. And so I join all the calls to see how the enrollment is going, and what is a clinical experience. And in our experience, patients are starting to show some responses, and it's going to be another drug that will be evaluated for approval based on the data. So yes, that is one clinical trial that you couldn't get access to at your local, your nearest academic center or place that has this trial available. We have it open here, and maybe Dr. Sahni and other institutions in Boston have it open as well.
All right, thank you.
So that's one that.
We get a question on nutrition quite a bit, and this one's the question is, what is recommended diet for someone with Sezary? But I think maybe if we can answer, is there a recommended diet overall?
I've been asked that multiple times. I always tell my patients a good, healthy, balanced diet is the correct diet. There's nothing that we know that definitely predisposes to Sezary or that makes it worse or better. And the treatments can cause side effects themselves. The condition is something that takes quite a bit out of the patient. So I think looking after yourself and having a balanced diet is key.
Yeah. And, a lot of our patients do come in with questions about supplements during chemotherapy. And so, we would review those with you, and you should review that with your treating physician if you are on active chemotherapy about supplements as well. But what I like to do is use an opportunity to talk about diet as a state of general health and to improve, diet in your eating habits and increasing the amount of antioxidant type foods in your diet have some benefit. And so we usually go into conversations about health, and because diet just isn't a treatment for cancers, but it can just improve overall health if you pay attention to your own diet.
Well, the doctors always tell us to eat healthy and stay active. So no matter what, that's what we should be doing. All right, and our next question. For a patient you've treated with romidepsin, I can always say that one, romidepsin, still can't get it, who have achieved a complete remission, thank you, complete remission with no sign of disease. Have you ever discontinued use, and if so, for how long? And it's a multi-part, so we're going to leave it up for a little bit. Did the remission continue? My mom is now taking it every 9 weeks. Complete remission for nearly 7 years. Romidepsin.
We've had a few patients who've done very well, and then we've done the same things. We've tapered off the dose, and then longer and longer, and then kind of given them a break from the drug. I think it's better if you can put them on some sort of maintenance treatment, something like extracorporeal photopheresis, just to help prevent the disease from coming back or to prolong the response. But as Dr. Lansigan had mentioned before, we want to keep those patients under close review. They should always have our contact number in case something is breaking through. But definitely we've had full responses.
I agree with that comment completely.
Very good. How long can someone use bexarotene capsules?
I think as long as it works and you can tolerate it. I don't believe that there's any long-term, reasons that we're aware of to stop.
Yeah.
All right, thank you.
I
And
agree.
I want to remind.
Go ahead. Go ahead, Lon.
Sorry about that. I wanted to remind everyone to use the Q&A to ask their questions. We are getting down to the last few that we have, and we have plenty of time. And while we have the doctors here, let's take advantage and ask questions. I have had a double mastectomy and am now undergoing chemotherapy with Taxol and with a targeted therapy drug, Herceptin. They seem to make my mycosis fungoides itchier. My oncologist said the therapy could even help with my skin. After 4 treatments, that is not the case. Do you have any info on results like that?
I'll take a stab at that question. And thank you for the question. It becomes complicated when second cancers appear in, I guess, like cutaneous lymphoma. And we just don't know, the effects of the drugs on the mycosis fungoides. Taxol and Herceptin, they're not really approved drugs for cutaneous lymphoma or CTCL, mycosis fungoides. So we can't expect any particular response from those 2 drugs. I think, you could be hopeful that, a certain class of drugs might help in this situation. But if the mycosis fungoides needs to be treated, I would ask, or I would probably have to use a treatment that directly affecting the cutaneous lymphoma, and not rely on the breast cancer drugs to do that, because it's unpredictable what those drugs can really do. Everyone will have a different reaction, actually, to the chemotherapy, and so if you're experiencing itchiness, then I would speak to your oncologist. And I'm not sure if that oncologist treating your breast cancer also has expertise in treating mycosis fungoides. But those 2 drugs are not expected to really do much for the mycosis fungoides, in my opinion. And you should maybe ask a question about treatment for mycosis fungoides at that point.
All right, thank you very much. Our next question. I've had typical male pattern baldness for years. Shortly before diagnosis in June of 2022, I lost most of my hair on my sides and back. Over the last 3 months or so, it has started growing back. Do you typically see this? Is this normal? Any insight? So everyone's dream, their baldness is getting reversed.
So the question is, what caused the baldness in the first place? Was it just male pattern baldness? Because mycosis fungoides also itself can cause hair loss, as can a certain type of mycosis fungoides called folliculotropic mycosis fungoides, which particularly goes for the hair follicles. So I've definitely had patients who've lost hair on their head and hair on their body, and that's been because of their mycosis fungoides. And with treatment, not all the hair, but a lot of the hair has recovered back, because sometimes the hair follicles get completely damaged in the process of the tumor. And so once the follicle is damaged, the hair can't grow back in that place. But if the follicles remain undamaged and the treatment is working, then typically you will get hair growing back. But the relation to the male pattern baldness, I don't know. I can only guess that there was 2 types of things going on.
All right, thank you. Not a new cure for male pattern baldness. All right, next question. My doctors for Sezary say no problem for me to have a total hip replacement. What do I tell a surgical team about how to care for my skin over my ankles where it tears if you look at it wrong? This patient had put in a few more pieces in it. It wasn't enough room in the chat bubble. The concern is that if he's sleeping when they move them, they're going to stress the skin, cause it to rupture, or to just overall, how can I express to them to be extra careful in caring for me?
I think type of dressings would be good. So typically you want to stick to non-adherent dressings so that it doesn't put extra pressure on the skin when you're changing them. and things that can help with wound healing, such as zinc-based products, depending on how deep the wound is. But if it's a superficial wound, then zinc-based products or Vaseline, petroleum jelly Vaseline, they're very good for wound healing. So I think, looking after the skin with sort of a gentle cleanser, using something like Vaseline as a moisturizer, and using dressings that are non-adherent, those would be my main recommendations.
And if you have an opportunity to, ask your cutaneous lymphoma oncologist or dermatologist, I think that's great because I don't know the amount of Sezary cells that you have in your blood and how well controlled it is, or how extensive your skin disease is at the moment. But or I tend to do a lot of consultations, prior to surgery to check in with the patient before they go for the surgery, and at that time, that's where I can offer recommendations. So I recommend you do the same with your oncologist and have the oncologist or the dermatologist, whoever's managing you, speak directly with your orthopedic surgeon.
All right, thank you both for that. Our next question is how is large cell transformation confirmed diagnosed with someone who has Sezary?
So typically with large cell transformation, the disease is sort of taking off. I say it's sort of progressing rapidly. It's not doing the usual kind of thing that we're used to. And most of the times it's with larger lesions that appear on the skin. So often there'll be thicker plaques or large tumors that appear rapidly and suddenly. And the diagnosis is made by a skin biopsy because there are certain features that the pathologist will look for under the microscope to specify whether it's large cell transformation or not.
We are getting fast and furious questions in the Q&A now, so we're getting some of our live questions here now. So our next question, this is a toughie. In your opinion, and it is opinions and hunch, as to whose disease will progress? If so, what are the tells? So what do you typically see on someone whose disease does progress?
I don't know, we can both probably share our experiences, but I see some patients who the lesions appear in a restricted location on the body. It's always in the same place. Whether they treat it or not, it comes back only in that place, and it goes on for years. So it kind of tells the patient that not much is happening. It's not changing dramatically. It's being very indolent. And so the amount of body surface area, I think it gives an indication. So the less involvement, typically, less likely to progress. And then I've also had patients who have, larger areas of their body involved. But again, the disease is still very much, you treat it, it goes away, but then it kind of comes back in the same place. So it doesn't seem to want to move. So those patients kind of, I feel, are unlikely to progress. Somebody who usually progresses, typically they present, very rapidly, all over body rash. Everything it's very speedy. Having said all that, we have had changes in patients, who've had sort of pretty indolent disease and then all of a sudden started developing, larger plaques and tumors. And so that can happen to anybody, and that can happen without warning. So and typically when that's happened, we don't predict that's what's going to happen. So I think, and I've also had patients with very rapidly evolving disease who have responded to treatment and then have maintained a good response. I think it can go either way.
And I'll share some experience too. Is that that, like I mentioned earlier, there are certain diagnoses that we watch a little bit more closely, and that tends to be the gamma delta T cell lymphomas, and sometimes anaplastic large cell lymphomas, cutaneous anaplastic large cell can tend to come back. So it does depend on various factors on the diagnosis itself. And there are sometimes proteins on the tumor or on the cancer under the microscope, then can give us some certain clues on who to watch. And in our clinic at Dartmouth, I see patients alongside with a dermatologist. And so she's doing a full skin check, and I'm also just looking as well. And so we get to know our patients really well. And if there's any change, that's when we both will talk about what that change might represent with you.
And that just perfect point of stressing the importance of a multidisciplinary. I'm just having trouble today. Multidisciplinary. All right, someone say it for me because it's just not coming out.
Multidisciplinary.
Oh, Jiminy Cricket clinic, and thank you. Oh boy, one of those days. All right, let's go with our next question after that, Flub. How often and what blood work should I have for maintenance of my mycosis fungoides 1B?
In general, so when you say maintenance, I'm guessing that you don't have much rash and that the disease is pretty well controlled with whatever treatment you're on. We don't routinely do regular blood tests. The time to do blood tests is if your disease suddenly worsens, so it was a much more localized disease and suddenly becomes much more rapid and widespread, or you develop lymph nodes. Some other feature suggesting a change is typically when we do the blood tests. Or if you're on certain treatments, for example, if you're on bexarotene, or interferon, you would want to do blood tests because those treatments themselves cause abnormalities. But typically, if it's just for the mycosis fungoides, we don't routinely do it.
Okay, thank you. Are there any known causative environmental factors for LYP? I get 1 to 7 lesions every 1 to 2 weeks, but then I was away on vacation for a total of 7 weeks and none appeared. Ooh, a 7-week vacation. Very nice.
Basically. So LYP responds very well to UV light, and that is actually one of the treatments for LYP and can have a reasonably long-lasting effect in cases where it works. And so I don't know where you went on vacation, whether it was somewhere more sunny where your skin was more exposed to the sun. But if that was the case, I can see how the LYP may improve in a situation like that.
Very nice. Get some sunshine and feel better. I think I am early stages, diagnosed on the 3rd of December, but don't meet with the team of hematologists, lymphoma specialists, and radiation oncologists until mid-March. Seems like a long wait. Is this normal? I am in Australia.
It also depends.
I think the problem is access. We would love to see patients as soon as they're diagnosed, but the reality is that we're really busy, and cutaneous lymphoma is a rare disease, I guess, and it's sometimes hard to get in to see a specialist for this disease. The good news is that most patients can wait, and if you can tell how soon you need to see someone. If it's changing rapidly, then you might be able to call and push that appointment earlier. But typically, yes, I mean, in our clinic, there's often a 1 month delay, and we'll triage our patients to see who needs the more urgent care. And we can tell from looking at the referral, the pathology report, and some of that initial information. And so we might, schedule someone earlier based on the severity of the disease at the time that they're referred. But most patients, I think, can wait, and March seems like a reasonable time period as long as you're not having rapid progression of any skin lesions.
All right, thank you. What markers are used to determine the best course of action treatment for someone with Sezary? Context: a PET scan showed swelling in lymph nodes, so my mother was put on 6 rounds of CHOP. Is this a common and effective treatment path?
Mm.
Let
Okay.
Dr.
Yes. Yeah. You want to take that first, and I
No,
think
I
both of
was
us
meant to
probably.
let you do it. Yeah. I mean, I'll
Oh
let
yeah.
you, yeah,
Okay.
'cause therapy, I
Yeah.
think it
No
makes more.
problem. Yeah. It's a chemotherapy question that is my specialty. So. Um, I think it's if you have a new diagnosis of Sezary, there are a number of treatments that are available that don't fall into the category of traditional chemo like CHOP, and those can be considered as well. Um, and we mentioned a few of them here on this call already. Um, Drugs like mogamulizumab, drugs like uh, romidepsin. These are good for helping to clear out the Sezary cells from the blood. And so, uh, while CHOP might be effective, it may not be good at maintaining the response. And so, uh, the key really is disease control after that initial response. So I would recommend, asking the oncologist to consider some form of maintenance therapy to help the disease uh, prevent it from coming back, really. Um, and there are not very many treatments that um, prevent sorry. There are not many time-limited treatments like CHOP. You get 6 cycles and then you stop. But after stopping, there's a high risk of it coming back. And I would also say that Sezary, not all Sezary needs to be treated. We have success with a blood procedure called photopheresis, which I mentioned earlier. And that alone, that procedure, it's a blood procedure where we take out blood, we treat it outside of the body with UV light and a chemical, and we return the blood back to the patients. And that treatment alone is not chemotherapy, and it's very effective at controlling and at treating Sezary. So that might even be a nice option if it's available in your area to consider something called photopheresis as maintenance therapy after CHOP.
That was wonderful information. Thank you. Our next question, what we just saw that one. Sorry, I'm reading and I'm like deja vu. Another MOGA question. What side effects have you seen with this treatment? Any that affect vision, for example, or joint pain?
The ones I've most commonly seen are rash, the kind of red rash that happens quickly, infusion reactions. Those are the two main ones, and increased risk of infection. I haven't come across ones with vision, but I'd be interested to hear what Dr. Lansigan says.
Yeah, so mogamulizumab, it targets a protein called CCR4, and so some some patients might react in a way that it causes what we call autoimmune disease, and so the joint pain could be something that's related to something autoimmune going on. And I have seen side effects where the mogamulizumab has caused an autoimmune arthritis, and then stopping the drug that tends to resolve. Um, so the other thing with vision is that there can be some autoimmune diseases that affect the eyes. Typically, it's more like a dry eye type of side effect, and something called Sjogren's disease. That would be the autoimmune disease affecting the eye. But vision itself I have not seen many patients with specific visual complaints, but it's certainly worth looking into if you've been on the MOGA, and this is something that's a recurring problem or a new problem since starting the mogamulizumab.
All right, thank you. And you're showing off by saying the full name of MOGA. With my pronunciations today, I'm not even going to try and say it. I heard it's not suggested to cut out nodules, papules, bumps in the skin. I would like to know why this is the case.
So typically with mycosis fungoides, with LYP, I'm trying to think of any, with cutaneous B-cell lymphoma, all the ones where you can get papules, nodules. Typically, if you just cut one or two out, it doesn't affect the kind of pathway or progression of the disease. And what you end up doing, if that's all you were doing, you'd be chasing it. You'd be cutting one, another one would appear, and cutting that, another one would appear. And so, more importantly, you want to attack the whole disease itself with a drug or with radiation therapy and kind of stop it from starting up in the first place.
It makes sense. All right, our next question, with brentuximab, if peripheral neuropathy occurs, is it reversible and can treatment be restarted?
Yes. Good question. Thank you for the question. Yes, peripheral neuropathy is the most common side effect from brentuximab, and it was something we monitor very closely. Different studies have shown that it is reversible. Studies in Hodgkin's lymphoma, studies where this drug is used a lot as well. And if you stop it, it can reverse, but it takes time. It does take time to reverse, and it may not reverse all the way. So that is something to watch out for, and let your doctor know that it's happening so they can intervene and reduce the dose, because there are different dose schedules and dose levels that can be tried to prevent that from getting worse. Some other things that you might want to know about is that my practice is that vitamin B6 is something that I prescribe patients who are getting neurotoxic agents, and at a dose of 50 to 100 milligrams a day, that there is some evidence that can prevent neuropathy. So you might want to consider just going on a vitamin to prevent this, and to maybe even help reverse what's already.
All right, thank you. I want to do a quick time check. We have about 10 minutes left, and we have 5 questions in the queue, so we will try to get to everyone's questions if we can. How common is it to have lymph node involvement in stage 1A mycosis fungoides?
So technically, if you're stage 1A, it means you don't have lymph node involvement. So I'm guessing you were diagnosed as stage 1A, and then you're asking how likely it is. It's extremely unlikely. People with stage 1A have an excellent prognosis, and typically the disease isn't the cause of their mortality. Having said that, I would say nothing in medicine is ever 100%. And if you see this condition enough, once in a while you'll see something that doesn't behave in the usual way. So I'm not saying that you couldn't develop lymph node involvement in stage 1A disease, and that's why it's important to come check with your doctor and have your doctor check you out. But it's highly unlikely.
All right, thank you. Is it safe to get 10 minutes of full body sun daily?
Yes, I think it is. I think it's important. So it's how you get the sun. So if you imagine the midday sun in the summer time, that's between 11 and 3, that's pretty intense. You want to avoid the midday sun. So early morning sun, late afternoon sun. If you get 10 minutes, that's a healthy dose. You've got your vitamin D. You've got the effect that you want on your lymphoma from that. And then we typically say sun protector all other times. So yes, 10 minutes of full sun, but then go to your sun protection for the other times.
All right, thank you. And 10 minutes of sun just always seems to make everyone feel a little bit better. Just, as we're in the winter time here in certain parts of the country, and we haven't seen the sun in 22 days. Is it important to treat LCT and Sezary with the mentioned treatment options like photopheresis in tandem with chemo being used to target swollen lymph nodes? Or should these things be treated in silo? And remember the disclaimer from the beginning that the doctors can give their opinion based on what they have seen, and please do not take these as second opinions.
Yeah, so I think we mentioned earlier, if you had joined earlier, about different treatments for large cell transformation. It is one of the areas where the disease becomes more can be more aggressive, and so it definitely needs to be treated more aggressively at that point. And so in terms of the treatments, we mentioned different chemotherapies that can be used, Taxol chemotherapy, brentuximab vedotin. We don't usually, for large cell transformation, we don't necessarily need to pair it concurrently with photopheresis. But I think what we had mentioned earlier is that if large cell transformation were treated with, let's say, radiation, total skin electron beam radiation, or even focal radiation, sometimes maintenance treatment with photopheresis can be applied at that point. And it's also important to know if there's, I think your question is if you have Sezary cells in your blood and you also have a diagnosis of large cell transformation, that would you need photopheresis at that time? I think photopheresis is a great treatment for blood disease. It tends to be very active in patients who have active Sezary syndrome in their blood. And those are the patients that I would recommend it. But it doesn't need to be concurrent to your treatment. It can be considered afterwards, if that helps.
All right. We're going to be down to our last two questions. Can LYP be differentiated from ALCL beyond how it presents on the skin? Any difference detectable in a lesion sample in the laboratory that might provide advance notice rather than having to react retrospectively?
So there are different variants of LYP, not so much clinical variants, but if you look at them under the microscope, there are different histological variants, and they're sort of labeled LYP, A, B, C, D, E. I think there's an F as well. But those are something that the pathologist can see. It's not something that the clinician will see, because to the clinician's eye, all those ABCDs look the same. They just look like any other LYP lesion. LYP type C is the one that is identical in appearance to primary cutaneous ALCL, or ALCL, because it could be systemic or primary cutaneous. And that's the one that if the pathologist were to see it alone, so if the pathologist sees it but they have no clinical knowledge or they haven't seen the patient, they would not be able to differentiate LYP type C from ALCL. And that's when the clinician has to kind of put what we call clinico-pathological correlation. So how does the lesion look to the clinician? Does it fit more with LYP? Does it fit more with ALCL? Together with the histopathological evidence, and that's how the decision is typically made.
All right, thank you. We're going to try and squeeze in two questions because we have about 5 minutes left. Have you used low-dose subcutaneous treatment with Campath for patients with Sezary? Not the traditional infusion at 30 milligrams, but rather the 10 milligrams subcutaneous injected low-dose regimen, which I have read is less toxic to the immune system. It's a very well-asked question.
I can answer, and then maybe Dr. Sahni can answer as well with her experience from her group. We have used it, and this data actually came out from centers in Boston, Dana-Farber, etc. Have the most experience with the Campath regimen. I have used it, but I am not as enthusiastic as some of my Boston colleagues in that it does tend to deplete the immune system, not just B cells, but not just T cells, but B cells. Even at the low doses, we do recommend patients go on multiple anti-infectives to prevent infection because of the immune suppression that does occur. I think we have a lot of other options that I would use before using Campath, but that's just my clinical experience. And but a lot of places in Boston will recommend Campath for Sezary. It's not my first choice, but it is an effective option when I feel like the other choices are not cutting it.
I actually agree with Dr. Lansigan, even though our practice is in Boston. We experience where it's not our first go-to drug. We don't love it. That doesn't mean it doesn't work. It has its place. It can work. And it's all about the risk-benefit ratio. Like you said, there are other drugs that are available that have a better safety profile, that we're more used to using and seeing good responses. So we would always go with those ones first. But Campath is known to work, definitely.
All right, thank you. We're going to go with our last question of the evening. When diagnosed with stage 1A, I was told not to worry too much as the likelihood of progression is small. Not to worry about cancer seems foreign. How should this cancer be compartmentalized so you can move on with your life?
So,
I think my favorite, the thing that when I first started with the foundation that stuck with me is you are most likely to die with your disease than of the disease.
Yeah, definitely. And that's certainly true for stage 1A MF, as we've mentioned before. There are a few other conditions, other types of CTCL that also have a generally, good prognosis. So LYP, for example, and even B-cell lymphoma, marginal zone B-cell lymphoma is typically, people don't die from it. So unfortunately, the word cancer is attached to it, and because in a cellular way, it behaves like a cancer. But we know that stage 1A typically does not progress and does not cause the patient any harm. And when we talk to our patients about it, we usually say it's like having eczema or psoriasis. So it's something that's on your skin. It's not within your body. You can see it, you can treat it, it goes away. Sometimes it will come back and you treat it again. And kind of getting that mindset to think of it more along that it's a skin condition.
All right, I want to thank you both for taking time out of your very busy schedule to answer questions from the community for us. And before we leave, I wanted to ask if either of you have any parting thoughts.
So I want to thank the Cutaneous Lymphoma Foundation for really inviting us and hosting these very effective education sessions for patients. I've done a number of these, both through the Lymphoma Research Foundation, as well as the Cutaneous Lymphoma Foundation. And I will continue to do so because I think for rare diseases, we need forums like this. Patients have a lot of questions. And if you have the opportunity to log on to more, you can hear different voices of the different experts in the field. So I really thank you for your engagement today. And I hope that your health stays good in this new year. And again, please do talk to your physicians for recommendations of your own conditions right now.
I agree with Dr. Lansigan. I think this Cutaneous Lymphoma Foundation has this wonderful, patient advocacy group. There's so much information that's out there. It's a rare disease. It's complicated by the fact that there has different names, different stages, different treatments. And no matter how many times you go into the hospital, I think it's nice to hear it in different ways so that it really sinks in and it really makes sense to you. And wherever possible, always seek out a multidisciplinary care team. You need people who are, dermatologists, oncologists, radiation oncologists, all kind of involved in your care. And that might not be near to you, but if you can at least get your initial diagnosis and management plan and make it there sometimes and perhaps be treated more locally, more frequently, using that treatment plan, that would be my suggestion. So thank you for having us, and I wish everybody well.
Thank you both so much. And thank you everyone for attending and for submitting your wonderful questions. And my last ask of tonight is to please complete the survey. It is very helpful on us determining what programs to bring you. So have a good evening, everyone. Goodbye.